One of the ways that we measure how well we're doing as a nation is our infant mortality rate.
The infant mortality rate in the United States is considerably higher than any other developed nation in the world.
The greatest number of babies who die are birthed by non-white Americans, Puerto Ricans, Alaskan, American natives, and African Americans. And the percentage is very high.
The primary causes of infant mortality are birth defects and prematurity.
Of the most common procedures in the hospital, the top 6 come out of maternity care.
What are we doing wrong? We're making it more technologically advanced in our country, and we're not doing any better, and we're actually getting worse.
We're talking about infant mortality, the babies who die, and we're talking about the ones who survive.
It's obviously important for babies to survive the birth, but it's not enough.
Over 500,000 babies are born premature every year. Over 2.5 million children within a 5-year span that need special education, special medicine, special medical care, and psychiatric care. We don't have the resources.
The rate of prematurity in the United States has increased by 36% since the 1980s.
The neonatal intensive care and the newborn care has become so good that we're saving babies now, where before we used to have some problems with them.
The very procedures that help them to live often cause neurological damage and lifelong psychological effects.
These are the babies that really have the most problems in their own lives. Learning disabilities and behavioral problems. 26% of extremely premature babies were testing positive for autism screening.
The cost of prematurity in the United States per year as of 2004 is $26.2 billion. Medical costs, education, loss in productivity, etc. Those are statistics that hurt, and you're talking about babies.
African American women are at risk disproportionately for having a baby preterm. And as a woman of color myself, I can't quite understand how the pigmentation in your skin can impact you to the degree that you could actually be at risk for losing your baby.
Our resources really need to be focused on these particular communities and populations that are at highest risk. And for sure, those are the same ones that have the least access to comprehensive prenatal care.
Just improving survival outcomes is not what we're looking for. What we're looking for is a method to improve length of gestation, to improve access of care, to improve the person's personal health care, and preventing those very early preterm births. Saving not only the quality of life for these children, but of saving healthcare dollars.
We began with a situation probably, I don't know, 100 years ago or maybe more, where the #1 cause of death was related to childbirth. And it's still not negligible as a cause of death of young and middle-aged women. But we started with that situation and thankfully have developed a large number of abilities to detect risk and to intervene and to prevent the death of mothers and children. Where we get into problems is when we decide that other women than those who are clearly indicated to need them need to have interventions.
We intervene every step of the way in pregnancy, labor, birth, bonding, breastfeeding. We step in and intervene, and there are long-term consequences to that.
The interventions are not just benign, they do damage.
Most maternity practices that are commonly used in the hospital were never designed to be used at the frequency that we're seeing them used now. And none of the evidence supports this. A vast body of literature does not support the use of labor induction, epidural anesthesia, for instance, or cesarean section at the rates that we see it currently being used.
If you get an induction that's unnecessary and you're not really in labor, there's a 40% chance that you will end up with an emergency section.
Today, the cesarean section rate in this country is 31%.
C-sections are the most commonly performed operation in the country right now.
The cesarean is major abdominal surgery. It carries serious risks.
We have become a little bit cavalier in how long to carry the pregnancy. People are a little bit less likely to say, well, let's just wait until it's the right time. Now it's for convenience and for us, not for just the baby's sake.
It's suggested as one reason that our C-section rate is so high in this country is that that's driven by a fear of litigation. Using technology that doesn't necessarily help the birth process, that doesn't lead to better outcomes, and that in fact doesn't protect physicians who are sued.
We've gone from a cesarean section rate in the 70s of around 10 to 15%, and we're now at 31.8% and rising.
If you do an elective cesarean, you try to do it near the end of the pregnancy, what we call term. You try to estimate how far along the pregnancy is. They're thinking that a lot of these babies are done when they're not done. And then they do the elective cesarean, and they end up with a baby who is several weeks premature.
It is estimated that for every week that a baby is born before term, that they double their risk of having problems such as respiratory problems, feeding problems, temperature instability, sugar instability, learning disabilities, and behavioral problems.
We're playing roulette. And most of the time we find an empty chamber when we pull the trigger at 36 or 37 weeks, but sometimes we don't. And we end up with a baby that doesn't do as well and gets into problems. What could have proceeded naturally in order to get my vacation in on time or back to work for this particular business meeting now becomes something which threatens the life of my baby, or at least its health.
We know that the causes of prematurity and birth defects are things like poor nutrition, drug and alcohol use, extreme stress, smoking, physical and emotional abuse.
Getting good prenatal care is one of the most important things we can do to prevent both prematurity and also many congenital defects.
Starting before they get pregnant, because the nutritional aspects are so important. You can reduce your risk for having prematurity and all sorts of problems by stopping smoking before you get pregnant. So those are some of the things that I think preventive medicine is really where we should be at.
If no one sits down and explains to you the impact of what you're eating on your growing baby, you might never put the two things together.
Almost half of our mothers need government assistance to help with prenatal care. If we don't have good funding for prenatal care, then almost half of our mothers are not going to have financial help in preventing all of these problems.
All of the barriers that prevent women from accessing prenatal care, that feeling of being alienated from the system, that feeling of not being able to afford it. There's huge long lines of waiting, there's no child care available. What it does is it may lead to increased levels of complications because they're not in a care system that reinforces a model that talks about healthy preventive care.
The people who could be providing this prenatal care do not need to be surgical specialists like obstetricians. We can have midwives, nurse practitioners, family physicians doing prenatal care and making it more widespread and more available. We know that those early moments of mother-infant bonding are incredibly important in imprinting both mother and baby for the lifetime of relationship that they're going to be continuing. And we have disrupted that.
We know that the use of narcotics at any point then interferes with breastfeeding.
Studies now that show that when women have interventions that there's deficits in maternal-infant attachment and deficits in breastfeeding as well.
Every year new studies come out showing how breastfeeding prevents this aspect of death or this cause of death or the other. And overall it's just absurd that we ignore it.
Among the African American population, their breastfeeding rates are the lowest. Sadly, African American babies are dying at a higher rate.
A baby who's not breastfed has enormous healthcare implications and economic implications because they're more likely to get ear infections, they're more likely to get gastrointestinal disease, they're more likely to get allergies as they get older, they're more likely to get diabetes, autoimmune diseases, a host of ongoing health problems for the baby whose mother is not successful in initiating breastfeeding at birth.
In the U.S., after taking away the preterm babies, after taking away babies that had cancers and heart defects and things like that, babies who were fed anything other than breast milk had about a 60% increase in death as compared to those that were breastfed.
Midwives and family doctors primarily are the providers that we've seen in the research have the best outcomes.
Birth is a normal process, and then what we do as midwives is support that normalcy.
From the midwifery model of care, safety means less intervention, more personalized care, more individualized care.
We also believe in the judicious use of technology, so that what we do is suggest the lower level of intervention before we go to higher level.
As little intervention as possible in a quiet way, letting the woman come to her own birth experience in a safe way, but in a watchful way, as opposed to intervening along the way.
You do not need somebody with the skills of a board-certified OBGYN to do a normal vaginal birth.
The United States is the only industrialized country in the world that uses surgeons to attend normal childbirth.
And then we look at those other countries and we see that their healthcare costs are lower, their perinatal and neonatal outcomes are better.
The midwives do generally a better job with the average patient of getting her to delivery without interventions and without complications.
Families are formed around midwifery. It's really one of the most powerful ways to begin a family, and we've worked very hard to be respectful of that, to support that, and to protect that.
Keep it at home, and that's okay. But making sure that those patients are safe and that there's a safety net, that whenever they do get into trouble or there's a suspicion of a problem, that there is somebody that can take care of that baby and that mother in a hospital environment, because that may be the safest place for that mother to be. If the system is set up properly, where you have a safety net, where you work in collaboration and have a nice team effort, I think it can be a safe process.
A collaborative practice where midwives do the low-risk stuff, turn things over when something becomes high risk, consult when something is a question, will give patients a better opportunity to have better outcomes.
Midwives need to be welcomed into the hospital setting. They need to have privileges, so people don't feel like, well, I'm only going to have a choice of having a midwife attend my birth if I'm at home, and I'm not comfortable with home, therefore I'm now pressured into making a choice that's not right for me.
There are entire states where midwives are unable to find an obstetrician gynecologist who's willing to be available should women need to go to the hospital and access those services.
All women should at least understand the differences between a medical model and a midwifery model, and what you can expect from a medical model and what you can expect from a midwifery model. And it's a little bit concerning that there are two models, because if there's a better way to give birth, why aren't we all heading toward that goal together?
When you're having a baby, there's nothing really wrong with you. You're not ill. In all of the experiences that you have in your lifetime, having a child is one of the most miraculous and amazing times. And I'm so saddened by the amount of fear and trepidation and concern and worry that surrounds that event.
Care that's impersonal and mechanized and focused solely on a risk-based model really tells a woman that the process is faulty, that she's just a number in the process, and doesn't promote her participation in her own health care. I think that's where midwifery can really be a positive benefit.
We've gone so far off course in our prenatal care and in our public policy messages that most women don't think they can deliver a baby without technology-driven interventions. And we know certainly that that is just not true.
One problem with the way we're doing birth in this country is that the approach seems to be driven by fear of litigation as opposed to focusing on the evidence and being guided by the science. So if you're doing things because you think it's going to help you stave off lawsuits, I'm not sure that that's the best approach to providing care.
We need to begin to think much larger. We need to think much more long-term, much more to the future. What kind of care is going to promote health in this newborn baby for the rest of their life?
The midwifery movement, the doula movement, breastfeeding, and demythologizing, taking off the throne of worship, medicine, and using it for what it is, a powerful set of tools which are able to help us in a very natural process when things sometimes go wrong, but at the same time something that can hurt us if we tend to use it willy-nilly. I think those are the things we need to do.